What are some of the steps for a clinician to consider when there is non-response to one antipsychotic medication?
Well, the first thing to consider is, has the patient been taking the medication, number one? And if the patient has not been taking the medication, it behooves us to ask the patient, well, why is that? Is there a side effect issue? Is there an existential issue? Is there a cognition or insight issue that prevents you from taking it? Is there a family issue that prevents you from taking it? All the things that we know about for adherence. So if we have an answer to that the patient just is not doing well just because the pill is ineffective, then we have to move on to something else which is more effective. As I said, if there have been side effect issues which have made that a little bit blurry, was the medicine working but the patient was so sleepy that we weren't sure? Was the medicine working, or was the patient a little bit akathisic and we weren't sure? Then we should try and correct that. But most of the time, one dopamine blocker doesn't work, you go to you go to clozapine because probably the etiology is not the same in the two groups.
Okay. Are there any strategies that can be considered before clozapine is initiated? In other words, can polypharmacy be considered, a combination of two antipsychotics, for example, or augmentation strategies?
Usually augmentation strategies are disappointing. Unless there is the presence of a clear depressive disorder which can be treated, or there's the presence of a clear anxiety disorder which can be treated, then I think we have a very valid polypharmacy, that is to say, an antipsychotic medication with an antidepressant or some anti-anxiety intervention, or a psychotherapy for that matter, for depression or anxiety. But most of the time, polypharmacy, that is to say, two or more antipsychotic medications together, and remember these are all dopamine blockers, is not efficacious at all. The one area where I think we might have a little bit of a change is some research that I've done over the last 4 years or so back in Montreal at the Douglas, where we just by chance happened onto the combination of lurasidone and olanzapine. It was done through desperation because I see a lot of patients who take clozapine who are going code red, or who just refuse to take the blood tests, or who have no more veins, or who have other severe side effects, and who just refuse to take clozapine anymore or cannot take clozapine. And I looked simply at the receptor profile of clozapine and matched it up with olanzapine and lurasidone. Now this is I don't know, this is kind of elementary school science, if you like, because we don't know what clozapine really does. We know it does have dopamine blockade as part of its activity, but we don't know what the magic of clozapine is. But I thought, you know what, well, let's give it a try. And it actually worked in a number of those patients who were taking clozapine, who did well on clozapine, and who couldn't take the clozapine anymore. So we offered it to other people as a way of a step before going to clozapine with all the blood tests and other side effect issues involved with clozapine. And it was relatively successful. So it's something, I wouldn't say it's a gold standard by any means. I think there's still a lot more work to do, but we have enough confidence in this combination of lurasidone and olanzapine such that we use it throughout our hospital now, both for adolescent patients with psychosis and even in some patients with in the older age group, over 65, and of course in the adult group. And the average dose of this combination of lurasidone would be around 120 milligrams of lurasidone per day and around 25 to 30 of olanzapine per day. Again, it's not clozapine, but in some patients it may be an alternative. I'm not aware of any other combination that could be useful except for lurasidone and asenapine, which I've also done in a smaller number of patients, just because asenapine is often a little bit more difficult to assure because of the oral absorption and the bad taste, frankly. It's a good medication, but it does have some difficulties. Yeah. Another combination which would have the same potential effect, but I have had fewer experiences with fewer patients, is lurasidone and asenapine, because asenapine, of course, has an almost identical profile with olanzapine. Reason I haven't used it as much, I have used it with success in some people, but I haven't used it as much simply because it is a little bit more difficult to manage in my population with resistant psychosis. You need to keep it in your mouth for at least 2 minutes, and it does taste a little bit like cough medicine, so it's not as popular a drug for that population, but it is a very good medication. So lurasidone and asenapine might work as well.